My name is Dr. Jean McGill. I am in the private practice of orthodontics in both Easton and Stroudsburg, Pennsylvania. I've been practicing for almost 20 years. I graduated from the University of Michigan in 1995. And I also serve as an assistant clinical professor in the Department of Orthodontics at Rutgers School of Dental Medicine. I first became introduced to Propel in April of 2012. When I was an original beta tester for the product. I've been utilizing it in my private office since that time. And I also teach Propel to my residents. I've been a Propel patient myself. I've used Propel on myself. I've had friends practice on me. I've had residents practice on me. And so tonight we're going to talk about my journey with Propel. And so our goals for tonight, we're going to review the background of the company and technique briefly. We're going to discuss the utilization of the technique in my private practice setting. And we're going to wrap it up with case reports of Propel patients from my private practice. I have a wide variety of cases to share with you, things I consider to be difficult movements. I've got 2 impacted canine cases, an extraction crowding case, 3 non-extraction crowding cases, closing an old extraction case that was originally treatment planned for an implant, and we're going to wrap it up with an Invisalign case, and we should have about 5 minutes for questions and answers at the end. And so how does micro-osteoperforation work? This research we know that bone remodeling is the rate limiting factor in orthodontic treatment, and anything that we can do to try to speed that up will help us to see faster results. So research showing that dense bone is softened and helping us to increase our treatment movement about 2 times. So we're going to talk a little bit about the science behind micro-osteoperforation. I know a lot of you are already familiar with that. And so we know that when we apply a force on the tension side, we'll see bone resorption on the pressure side, causing the tooth to move in the intended direction. If we apply too heavy of a force, we'll see some undermining resorption and necrosis. Sorry, it's advancing by itself here. So we struggle as orthodontists to keep our force levels into an optimal zone so that we don't overwhelm the system. And so we're all familiar with the process of bone remodeling. We want to try to keep our force levels in the zone that facilitates it, and Propel helps us to soften up the bone, leading to faster remodeling. Okay, the science for what's behind Propel came out of NYU in a clinical study that was performed there. They looked at micro-osteoperforations in a clinical setting. And this work was published in the AJODO. The objective was to study micro-osteoperforations and also to look at the expression of inflammatory markers. This was a clinical study, and it was basically a split mouth study, very similar to what we did when we beta tested the product. It looked at premolar space closure. One side was treated, one side was untreated, and the treated side experienced space closure at the rate of twice of the untreated side. And so you can see the comparison of the treated side and the untreated side, and especially you can note in slide D that it's really obvious that the patient's treated side had much greater tooth movement than the untreated side. And that was calculated out to be 2 times the rate of the untreated side. And so key points to remember from the study is that we saw about 2 times the increase in velocity of tooth movement when looking at canine retraction. There was no tipping. Patients had very little post-treatment discomfort. And I can tell you honestly, as someone who has had Propel myself, it's really not a very scary thing. It's not very uncomfortable at all. I would highly encourage any of you who are considering bringing Propel into your practice to have a staff member go through the treatment or yourself. I think it really makes it less scary, and it helps to make your patients feel more comfortable. So we're going to talk a little bit about different modalities in accelerated orthodontics. And so basically there's 2 types. There's patient-controlled and there's doctor-controlled. And so first we're going to talk a little bit about the patient-controlled. On the left you can see there's a light-activated bone regeneration appliance. This is from BioLux. I don't believe it's out on the market yet. And it's very similar to the Accelerator in that it requires patient compliance about 20 minutes a day. On the right side, you can see, I'm sure a lot of you are familiar with the Accelerator product. It is a rechargeable device. The patient is required to self-administer for about 20 minutes a day. It's highly dependent on patient compliance. It's expensive. It's about $1,000 per device. I personally have experience with the Accelerator. When I initiated my orthodontic treatment, I purchased one. Actually, was deemed to be our office demo unit, but I still had to pay about $1,000 for it. I was really pretty faithful with it for a while, and then I went on a trip. I misplaced my charger, and that was pretty much the end of it. I found my charger about 6 months later, but I really haven't kind of gotten back into the swing with it. So I think the fact that it is highly dependent on patient compliance is a really downside to using that appliance. Plus, it really is non-specific as far as sight. It's moving all of the teeth all the time, whether you want them to or not. So if you have any anchorage issues, you're really not going to be able to control that with the Accelerator. And we can talk a little bit about doctor-controlled accelerated orthodontics. The slide on the left is a picture of a corticotomy. A lot of people know this as Orthodontics. Depending on which area of the country you practice in, you may or may not be familiar at all with this technique. Where I teach at Rutgers, we have a very strong relationship with our perio department. I've seen multiple patients who've been treated with the Orthodontics. Even one of my clinic patients at school was treated with Orthodontics for treatment of a lower molar, very similar to one of the last cases that I'm going to show you tonight, except that the patient was a lot younger. She was in her early 30s, and frankly, I was underwhelmed by the tooth movement that we got with the Orthodontics. I thought for what the patient had to go through and how much it cost, I really did not seem to think that it was worth the while for the Orthodontics. The middle slide is PCO surgery. Also, still, a lot more, less invasive, not quite as brutal a procedure as the Wilco. Still very expensive. Depending on where you are in your area, your periodontist may or may not be performing this. And on the right, we've got the micro osteoperforation with the Propel appliance. It is, not very invasive, very little patient recovery. The cost is very low, and the training is also pretty easy. And so this is taking a look at the 2 different types of Propel drivers. The top is what is called the Accelerator Driver. This is the original appliance. It is a disposable appliance. You can see where the arrow is. There's a dial-up for your depth. The really great thing about this driver is that it has a nice LED light on it, so when you get to the required depth, it lights up, and it's really very easy to see. On the bottom is the new driver, which has a sterilizable handle. The blue handle that you see is completely sterilizable. It comes with either an open or a closed tip. We like the closed. And the tips are completely disposable. They reworked the flute angle on the cutting burr, and it's really nice. It's a lot more quickly. It does things a lot faster than the old appliance. And so we're going to talk about benefits of micro-osteoperforation. Just to summarize, it really accelerates your orthodontic treatment with minimal discomfort to the patient. It can be used with either aligners or braces. The doctor completely controls the application. It's not compliance driven by the patient, and in today's society, a lot of patients are interested in this kind of technology. They want to reduce their treatment time, and they're willing to pay a premium for it. Plus, you're seen as a cutting-edge practice and up on the latest technology. And so we're going to spend a few slides talking about technique. You can use basically whatever anesthetic you are comfortable with. I've been using, as I said, I've been using the Propel technique for about 2 years. I have never felt the need to infiltrate with my patients. We've used a variety of different topicals. I'm going to talk about that in a couple of minutes. You can use whatever you like, whatever you're comfortable with. The topical goes by a couple of different names. You're going to palpate the area, evaluate your x-ray, have the patient use a chlorhexidine rinse for 1 minute at the beginning and 1 minute after you've completed it. And then you're going to use your topical. So dry the area off, use a small amount of the topical. We like to use the BTT formula that is listed on the left side. You know, we've gotten it before from a pharmacy in California. Currently, I have a mother in my practice who owns a compounding pharmacy. We order it directly from her. Some doctors like to order it in a syringe and use that for application. We just leave it in the container that it comes with in the refrigerator. That's really key. You get it onto the area with a micro brush, and then we'll usually put a piece of gauze over that, because once it starts to heat up to your body temperature, it starts to kind of get a little bit runny. I highly recommend having an assistant sit with the patient while you've got the topical on. If you're working on the lower, be careful. Maybe consider sitting your patient up for that. I did have a situation one time where a patient, and of course it was an adult female physician, kind of swallowed some of the topical because, you know, it ran down the back of her throat. We weren't really being super careful about it, and she kind of had a coughing fit and felt like she was losing her airway, and it was kind of a lot of drama. So definitely have an assistant sit there while the patient's getting numb. Rinse, dry, get the gel off, and have the patient sit for about 10 minutes to let the area get completely numb. Check it with an Explorer, and then you should be good to go. And so you're going to set your accelerator to the desired depth that you'd like to use. It is very similar to placing a TAD. You're going to rotate it clockwise until you get to the depth that you are desiring, and then you rotate it back. I usually will place most of my perforations on the buckle for ease of access, and with my exposures, I'll tend to go all around the tooth and then kind of lead a trail up to where the where I want the tooth to go, kind of like a trail of breadcrumbs. This is the Propel consent form that we use in my office. We will usually have the patient complete that form and sign off on it before we actually schedule the appointment. It just makes it easier, and it just saves time on the day of the appointment. We're going to talk about the fact that most of our patients will just do 1 or 2 treatments. There's very few situations where I felt the need to do more than that. Every now and again we'll do 3. You will be doing 2 to 3 perforations in an area. You're going to get a response that's going to go 6 to 10 millimeters around your treatment site so that you can kind of plan your sites accordingly. In the anterior, we will use 3 millimeters. We'll use 5 to 7 in the posterior, and on the palate, you're usually at 7 with that thick tissue. We used to use a lot shorter intervals. We were, going at 4 to 6 weeks, but now they have science that's demonstrated that you can get treatment effect to 10 to 12 weeks. So we've started to spread our treatments out further. And this just shows you're going to perform your perforations in either a linear or triangular fashion in the area where you want to have the effect, and that treatment effect is going to extend out. It's going to fan out about 6 to 10 millimeters. This slide talks about using accelerated treatment with aligners. You can use this either proactively, meaning you're gonna talk to your patient prior to the start of treatment about using Propel with their aligners, or you can use it actively, maybe if things aren't tracking well, or you want to try to avoid a refinement. My last case that I'm going to show is an Invisalign case, and my patient had 2 treatments, and she was very highly motivated, and she was able to get herself down to 4 to 5 days per aligner. And so again, with using accelerated treatment with the brackets, you can do it either proactively, meaning you start at the beginning of treatment and you talk to the patient about the fact that you'd like to use Propel before you initiate treatment, or reactively to get yourself out of a situation that's taking too long, or you've got some patient burnout. I'm going to show it both ways with my clinical cases, and I have to say that lately we've really kind of changed our mindset on it, where everything used to be all reactive, where we were just primarily using it to get out of situations or things that we just needed to kind of speed up the process, and now we're using much more proactive application, primarily with our adult patients who want to accelerate their treatment. I had a patient that I treatment planned yesterday who is missing 7 teeth. He would like me to close up as much space as humanly possible, and I told him I think that with Propel and some TADs, we can probably close up all but one space. I would say probably 1 tooth. This slide just shows immediately after the treatment, and you can see it's really very minimal. And having had this done on myself, it's really not that big of a deal. A little sloughing, maybe this is 30 minutes after, a little sloughing. Highly, highly, highly recommend. You need to talk to your patients about what medications they're taking. If they are on any nonsteroidal anti-inflammatory drugs on a daily basis for a medical condition, then you really need to rethink whether or not you want to use Propel on them, because the NSAIDs will shut down the cytokine response that we're attempting to accelerate with the Propel treatment, and so patients that can't get off those drugs are just not good candidates for Propel. So you want to make sure that your patients are only taking Tylenol for discomfort, and usually nobody really ever needs anything. It's very not a big deal. And so there's lots and lots of different cases. that that you can use. I mean, pretty much anything you can think of. It's really great for crowding. As I said before, it's really great for space closure, and one of my favorite cases is closing up an old extraction site that was originally treatment planned for an implant. We're going to talk about that later. I'm getting ready to use it on some Carrier distalizer cases. Invisalign works great. Pretty much, you name it, and Propel will help you out. So let's talk about some clinical cases. So the first case that we're going to talk about is Brandon. And Brandon initially presented, this is his original Panorex from May of 2012. And at the time, he's got some crowding, potentially both the upper right and the upper left canine look impacted. The left side looks worse. These are his initial photos. So we talked about doing an expander and potentially having those canines exposed. And I also talked about getting the primary canines removed. And so this was the treatment plan for him. We talked about the expander with the partial braces, getting a consultation for surgical exposure, getting the primary canines removed, and following that up with full braces. Unfortunately, Brandon kind of vanished and got the primary canines removed and didn't do anything else, and showed back up in our office almost a year later. So this is his Panorex from April of 2013, and you can see things are not looking too bad on the right, but that the canine on the left side is looking significantly worse. And these are his updated photos from his records. And so at this point, he was ready to start treatment. So we delivered his expander in May of 2013. We placed his partial braces. I use Damon negative torque brackets in the anterior. My usual protocol is to put them on about 8 weeks after we're finished expanding. We sent him for the surgical exposure of the upper left canine in September of 2013. A couple weeks later when he came in, I realized, I better remove the bracket on that upper left lateral so that that can just kind of move out of the way. And so at this point, this is about 4 months into treatment. We're seeing him, our usual protocol, we're seeing him every 3 to 4 weeks to reactivate that gold chain. And the tooth was progressing normally, but very slowly, in kind of what you would expect with a canine of this severity. And so at this point, I talked to Brandon and his mom about Propel. And so this is a case of reactive Propel. And so we decided to use Propel to accelerate the tooth movement. This is a very difficult exposure, and I feel that the Propel really, really helped to enhance our tooth movement. So our first treatment was on March 6th. Our second treatment was about 2 months later. At that second appointment, he came in and the tab was loose. He didn't notice that it was loose, so we took it out. We replaced it, and his final was December. So this is his x-ray from May. And that was taken this day of the second Propel application. And this is a photo when we put the tag back in. I just wanted you to see how we attached it to the button and chain. And so this is his Panorex taken in June, and I was really completely blown away by the amount of tooth movement that he was getting here. So this is 2 applications of Propel and 4 months total after our first Propel application. And I have to say, I think that I have probably saved, to date on this situation, I probably saved myself at least 6 months based on how well that tooth was moving. Here are some progress photos from August. The tooth was really making a lot of progress at this time. His mom was super excited that the tooth was visible. And so I calculated, you know, we generally see our canine visits every 3 to 4 weeks for about 15 minutes to reactivate that chain. So I think by using the Propel here, I saved myself about 8 activations of 15 minutes, or about 120 minutes of chair time. One thing I probably should have mentioned at the beginning is, in my prior life, before I went to dental school, I was a CPA. And so I'm all about chair time and office efficiency, which is why I really love the Propel. And even under best case scenario, you're figuring that your chair time is probably costing you about $6 a minute. I had a professor at Michigan who said, you know, chair time is the most expensive thing in your office. And so that is really how we view everything. So I figure I saved at least $720 worth of chair time, which more than paid for 2 wands for my Propel. And this is his Panorex that we just took in December. At this appointment, we removed his expander and his partial braces and scanned him for his full insignia braces. And these are his progress photos, and you can see how great that tooth looks. Really, the Propel really bailed me out on this one. This was really great. So our second case is Aaron. Aaron is another impacted canine. And these are his photos from when we first saw him. This is his initial Panorex. So you can see he's got ectopic eruption of the lower left 5, and he also has a severely impacted lower left 3. He was a little on the older side. He was, I think, almost 16 at this, but he was about 14. His treatment plan at that point was to get the lower left C and the lower left E out and see him back in about 4 months. I was planning on referring him to the oral surgeon, making room for the tooth. I told Mom, you know, we can try to bring it in and plan for an implant replacement if we're not successful. And so we saw him in April of 2012, and at that point I recommended that he see the oral surgeon, and I wanted to get his braces on and start creating the room for that lower left canine so that it could be surgically exposed. Unfortunately, he did not come back into the office for 9 months. He reappeared in January of 2013. These are the photos for when he came back into the office. You can see not much has changed. And this is the x-ray from when he returned in January of 2013. And so, I mean, this is a pretty significant impaction. I mean, this is not anything that's going to be easy by any stretch of the imagination. And so, treatment summary for Aaron: we placed his full braces in February of 2013. By November, we had enough space for the canine. We referred him out to the oral surgeon. He had his tooth exposed the following January. He had a lot of broken brackets. He had a lot of missed appointments. And so I spoke to his mom about reactive Propel. And so what we wanted to do was get him kind of kickstart his tooth movement with the Propel. In March of 2014, we placed a TAD between the lower left 5-6, and we propelled him about 6 weeks later, actually about 2 months later. And so this is the pano that was taken at his initial appointment when we did his first application of Propel. These are the photos from that same visit, okay? And really happy with the progress that we're seeing with the Propel. This is a very ambitious exposure. I figure that at this point the tooth is probably moving at twice the rate that it would have normally. Progress photos, again, from that June visit. And again, I mean, the tooth is really moving very quickly. You can see the end of July. You can see in December, again, really making great progress. I can honestly say I do not think that I would have been able to get this kind of tooth movement without the help of Propel. Some photos. Still the tooth is not visible. And we talked about the fact that we're going to do some more Propel for him. He's coming in a couple of weeks, and this is definitely one of those cases where I think doing more than 2 applications is warranted. So our next case is Nikki. Nikki is a crowding case. This was her initial Panorex taken in 2012. Her initial photos, you can see she presented with a lot of crowding, a really skewed maxillary arch. Her upper right 3 was completely blocked out. Her treatment plan was to use Insignia custom braces and to order the extraction of her second premolars. In November of 2012, we placed her full braces. That same day, she went to her family dentist to have her premolars removed and unfortunately had a pretty bad experience. You can see from the photos, she had a pretty bad extraction appointment. On the upper left, you can see, I don't know what they did there, but they took away a ton of bone. And that has been the bane of my existence the entire time with this case. I'll show you in a later photo that is the last space to close. It really is a very, very difficult area with that defect. So unfortunately, she had such a bad experience at her extraction appointment, she was not able to even tolerate letting us have any wires in there for at least a month after her extractions. So this is a follow-up in May. And you can see, I mean, it's upper left 5, still very slow to heal. And so at this point, you know, things were kind of moving slowly, and we talked to Nikki in February of 2014 about having some Propel treatment. She was very anxious, got the Propel, you know, basically a month apart. Could have probably been a little bit more efficient with it, but she was very anxious and wanted to get it done right away. And so these are the photos that were taken the day of her initial Propel treatment. This is at the second visit, and this is when we saw her recently, and you can see almost all the space is closed up. We're still having a hard time with the upper left, lower right, a small amount of space there, but she's getting down to the end of her treatment. And so we're going to move on to Wanda. So I first saw Wanda in 2009. At that time, she decided that she was going to take care of treating her son, and then she came back on my doorstep about 5 years later. So these are her initial photos. And so her treatment plan, she had narrow arches. Her treatment plan was to place Insignia custom Damon braces. We were using Propel proactively here. I talked to her about it at the beginning of treatment. She just wanted to get her braces on and off as fast as possible. We were going to be using crossbite buttons and bite turbos to help aid in that crossbite correction. We put her braces on May 19th of 2014. She had her Propel first treatment done a couple of weeks later, and another treatment done about a month after that. And so these are some progress photos from her second Propel treatment. And you can see, I mean, it's really, you know, you can see a little bit of bleeding, but not too much. She's really thrilled with the progress that she's getting. I think things are moving along really nicely. These are some progress photos from August. And these are some recent progress photos from November. At this point, you know, she's now in 1925 TMA wires. She's getting some really nice arch development. She's been in treatment for about 6 months at that point. I think we've probably saved at least 2 or 3 months here of treatment, so definitely well worth using the Propel in her case, and she's thrilled. So our next case is Ron, and Ron was part of my original the beta testing group that we did for Propel back in April of 2012. There were two different types of cases that were used in the beta trial: the split premolar extraction cases, like I showed in the NYU case, and then Ron was what was considered a registry trial patient, where we basically, used it on other cases that did not fall into the premolar extraction case. Ron was about 58 when we started treatment. His treatment plan was for Insignia custom braces to relieve the crowding and Propel to be used proactively. Because of his schedule, he owns his own business. We ended up putting his braces on and doing his first round of Propel actually the same day, which was the day that we were being trained with the appliance. We used another round of Propel about 6 weeks later. He had a little delay. We removed his braces for his son's wedding. He also had a lower premolar that kind of fractured and needed a root canal. So he had a couple of treatment interruptions. You can see, really difficult to unravel that lower arch. Lots of tori, lots of crowding, had to stay in light wires for a fairly long time. Getting some really nice alignment there. Things are kind of moving along. And that was his debond in August of 2014. So I felt that, he got a really great treatment result, that the Propel really helped to keep him on track. That's his final D-band Panorex. And we're going to move on to Joanne. Joanne's a non-extraction crowding case. Her initial Panorex is not really very remarkable, except for the fact the upper left 8, we had that evaluated at the oral surgeon. He recommended that we leave that in. He felt that it would cause a bony defect if we took it out. You can see her initial photos. She's a proactive Propel case. I talked to her about using Propel right at the beginning. She, wants to get her treatment done as quickly as possible, but of course she's a school teacher, so she only wanted to have Propel when she got out of school. So we talked about using Insignia custom Damon braces to relieve her crowding and expand her arches, and to treat her with Propel proactively. And so her treatment summary: her braces were placed in March. Like I said, she wasn't going to have the Propel until she got out of school, and then she wanted to have it, back to back. So we did one application in June and another one about 3 weeks later, which is really not what I want to do, but we were on her timetable. Like many adults, just keeping her braces on is a major challenge. You can see she's got nothing but crowns, not very good surfaces for putting any kind of bite turbos. The lower anterior, total challenge. This is the first day that we did the Propel. Not too bad. I treated the upper and lower anterior here. Again, about a month later, second application. And that's really the minimal amount of time that we will do in between. And if people are really honest, if they're really pushing us, we will do a 4-week interval. But actually, as I said before, 10 to 12 weeks is optimal. Here's Joanne in November. She's really thrilled. I'm really thrilled. I think the tooth movement is really clipping along nicely. You can see that lower right 2. That's always going to be a problem for us. I said to her recently, hey, Joanne, why don't we Propel that area again? And she, oh, well, okay, maybe when I'm out of school. So she's on her own timetable. This is one of my favorite Propel cases. This is Anne-Marie. Her initial Panorex, you can see she is missing the lower right 7. Her initial photos, she presented with a class 1 right, class 2 left malocclusion. Her upper midline was significantly to the right side. She was missing the lower right 7, and we treatment planned her possibly for an implant. I kind of wanted to see how things were going. Facially, I did not really consider her to be a surgical case, and we talked about extracting the upper left 5 to correct the midline and said we would reevaluate for possible space closure on the lower right. And so her treatment summary, we placed her braces in July of 2012. She had a lot of broken brackets. She was a smoker, which I really think slowed her down. So this was another case of reactive Propel. So in March of 2014, we talked about using Propel. I'm sorry, that was in January. We talked about using the Propel and the TAD to bring that lower right 8 forward and close the space up and not have to have an implant. So these are photos from her second appointment with the Propel. These are photos from this summer. You can see the movement is going along nicely. Again, in July, I'm sorry, September, you can see the space is closed completely. And we just need to spend a little time to do some detailed finishing at this point. And she's scheduled to get her debond in a couple of weeks. And so the last case that I have to show you is Nikki, who was an Invisalign patient. And this is her original pano. She, as we talked before about the fact, a lot of people are using the Accelerator with the Invisalign. I really think that Propel has a much greater indication with Invisalign because basically you just use it where you need it. Her treatment plan was to use Invisalign to expand her arches and resolve her crowding. And so her treatment summary, we placed her attachments. We gave her her first treatment of Propel in March of 2013. About 6 weeks later, we gave her her second treatment. I treated, as I said, the upper and lower anterior 3 to 3. I mean, initially she was so crowded she couldn't even get her aligners in and out of her mouth. Between the attachments and the crowding, she was, kind of standing up by the mirror for like an hour. After the first treatment, she told us that she went from 14 down to 6 days per aligner. After the second treatment, she was down to 3 to 4 days. These are some progress photos from April. This was the day of her second Propel treatment. These are from June. At this appointment, we gave her 24 to 26. She had 26 total aligners for her treatment. We scheduled her to come back for final, take the attachments off. We gave her cemented retainers. And unfortunately, she wasn't really great about getting back in for some final photos. So these are the last pictures that I have for her. And they still have attachments on. She is a hygienist at a referring office. She's thrilled with her treatments, thrilled with the Propel treatment, and has referred lots of people. So we're going to talk a little bit about practice management. Basically, you can do what you want, but how I kind of chose to roll Propel out in my practice was I hand selected some people that I wanted to treat at no charge, basically to give me testimonials, to get me great before and afters that I could share with other patients, and help to get other patients to agree to treatment with the Propel. I would encourage you to take the time to develop your technique clinically. Give yourself a break. Definitely schedule an hour for the appointment. You are not going to be spending an hour personally with your doctor time. In our office, we schedule it for an hour because that's the amount of physical time the patient is generally here. My time in that appointment is really about 10 minutes. So we'll see these patients in the morning or early afternoon. My time, again, is really short. It's only about 10 minutes. If we're doing something really quick and easy, like a single tooth procedure, we'll pretty much do that anytime. But again, because of the anesthesia, they're going to be in the chair longer. how we've worked this in our practice is we've used it either as a promotional add-on or as an upgrade. For instance, last fall we did a fall special where patients choose your upgrade, either a $500 off full Invisalign, 2 free Propel treatments, or free clear braces. This just helps to create buzz. And so now we're going to have time for some questions. I can't read the whole question. It says, how would you use...
You're having a hard time. I'll read them out loud to you.
Okay.
How would you use Propel with Invisalign?
How would I use Propel with... I will use Propel either proactively or reactively. I will use it right at the get-go, like we did with Nikki. For somebody who just wants to get done as fast as possible. And the patients that Nikki sends over, she shared her experience with Propel. They all want to get done as quickly as possible. So we are starting them right off the bat and doing 2 applications. Generally, that's all they need. We've also used it reactively where, we've gotten situations where patients are not tracking, and you can Propel the area and, maybe have them stay or go back a few aligners and hope to catch them back up so that you can avoid a refinement.
Great. Second question is, I've used Propel.
So the next question.
Yep. I've used Propel on my 12-year-old with very dense bone to help move the midline, which was accomplished in half the time according to her orthodontist. Will there be a motor-driven device for the very dense bone in the future?
I can't really answer that question. I don't know. I think everything at this point is still with the current hand application, the wand. And I don't know, Donna asked that question. I don't know if Donna has used, I have to say there is a significant difference in ease between the older style or disposable wand and the sterilizable wand. They really improved the cutting tip on that burr, and it's like going through butter. I mean, so I don't know if the person who asked that question is using the disposable tips, but I think that the new ones are really nice, and the cutting burr on them is great.
Great.
And I get the question from David. Next question.
Yes. How much do you charge now for Propel?
We currently charge $500, which I think is a steal. I mean, I've got friends out there who are charging, if they close a space up, like in that case with Anne Marie, if you're closing a space up for someone, I've got friends who feel no problem with charging $2,000. I'm in a very blue-collar area. That's just not going to fly. And so I have no problem at all charging $500. It more than covers my cost of my wands. Where I see the benefit is it saves me chair time. And like I said, I mean, if you, at a minimum, if you calculate out $6 a minute for your chair time, which is a really conservative number, anything that you can do to save chair time on your patients. That's why I started using Damon. That's why I started using Insignia. That's why I started using Propel. So anything, I'm completely comfortable with $500. And it worked really great for us in the fall with our promo, where we kind of, really use that to kind of kickstart the fourth quarter sales and try to get people to sign up and agree to treatment before the end of the year.
The next question.
So the next question
from Uttam Paul. What are possible complications of, while using Propel?
What are possible complications?
Yes.
I mean, unless you had a patient who had a bleeding disorder that you weren't aware of, I don't really none that I can think of. If you leave your anesthetic on too long, the patient is going to get some tissue sloughing. like I said, I had that situation with the adult female physician who, unfortunately swallowed some and then had a big coughing fit and, felt like she was losing her airway. But from a mechanical standpoint, I don't really see any downside to it. And really, beyond those couple of things that we talked about, I don't really see any downside.
In some of the clinical cases I saw, only one application of Propel between every two teeth. Is that enough?
Yeah, I will get in there and I will basically, like I said, the treatment, it's going to go 6 to 10 millimeters in either direction. So I will tend to go in the lower anterior. I will tend to go in between each tooth. And then I will definitely go mesial and distal to my canines. And then I'll go, if I'm doing full mouth, I'll go back and do one in the bicuspid area and one in the molar area if I'm doing full mouth. And with the new wand, I mean, you can go all day long with that thing. You can make as many perforations as you want, and it's not like it's going to get dull or anything on you. So.
The next question from Donna. Do you recommend a month in between Propel treatment?
Initially that was the information that we were going on, but now basically they have science demonstrating you should go 10 to 12 weeks in between, and so that is what we switched to. So our protocol now is to spread it out longer and to go 10 to 12 weeks. We were going 4 to 6.
Great. The next question is resorption a concern using Propel?
You mean root resorption? No, I have not seen it really in I have not seen any of my cases.
The next question is, if the effect lasts 10 to 12 weeks, why are only 2 treatments needed if the treatment time is longer than 20 to 24 weeks?
It just seems like it just kind of kickstarts the tooth movement. I don't know how to explain it except to say that, I mean, it's basically like, especially with those impacted canines. I mean, typically, you're pulling on those things every 3 to 4 weeks for a year. I mean, especially with some really nasty ones like the one I showed, like Brandon or Aaron. And you're spending a lot of time. It just really kind of kickstarts the tooth movement, and everything just kind of seems to happen a lot more quickly. So we generally will just do the 2 treatments, and like I'm going to do an extra treatment now on Aaron, and I offered Joanne an extra treatment for that lower right lateral for something that I think is just not moving along. But from a pricing standpoint, what we include is 2, and I think it's it's safe to say that the overwhelming majority of your patients are only going to need 2. So whatever you feel comfortable with charging, if you're going to charge it based on 2 applications, it's so rare that I think that you need to go beyond that. It's not like you're going to lose money on it. If every now and again you have to give somebody an extra treatment, it's not going to be a big deal.
Great. What is the youngest age Propel is recommended for?
I don't think that there's any specific recommendation. Probably the youngest patient that I've used it on is 12. I don't think that, and like I said, Joanne was in her mid-60s, so that's my highest endpoint. But I don't think that I don't think there are any directives or anything in regards to age.
Wonderful. So the next question is, how do you minimize the invasiveness of it all? Topical all over, blood afterwards. It seems like a procedure where people will be anxious.
I don't, I mean, we have some, some very high maintenance people in my practice and very, prima donna, difficult people to deal with. I mean, really, once they commit to going through it, I only had, like one patient actually get into the chair, see everything set up on the tray, like just, I mean, see the wand and then just kind of say, I can't do this. The overwhelming majority, I mean, really only the one patient kind of bailed out. Everybody else is, I did a video of me doing Propel on myself and filming it with my phone in our mirror at the office. We show that to them if they have any questions or concerns. And that's why I said before, I would highly recommend when you get ready to roll this out in your office, do it on a staff member. Do it on a staff member. Take a video with your iPhone, so that person can be a resource for you that you can turn around and say. I mean, my girls will say, yeah, Dr. McGill did it to herself, or it really kind of makes people realize it's not that bad. We use language like saying, we're going to use a little wand to do poke holes in your bone to soften up the bone. We don't talk about burrs or anything kind of graphic like that. I mean, we really kind of try to keep it light. And it's, it's like when you were in dental school and you were giving a patient a shot. It's not like you're, whipping it out in front of their face or anything like that. I mean, you don't have to have it sitting on the tray for them to see it. So most patients they're pretty good with it. And they know that usually it's an easy in and out. They're comfortable with the topical. I personally was comfortable with the topical. Our patients are comfortable with the topical. They really, it's not a painful, uncomfortable procedure at all. But I think if you get someone in your office to get treatment, I think that really helps to make patients feel comfortable with it.
Wonderful. The next question is, would you use Propel on the lingual palatal for very dense bones?
We have, it's a lot more difficult, but we've like for certain canine applications, you can feel when it's like putting in a TAD. I mean, you can feel there's a different feeling when you get into the bone, and that's how you can kind of gauge if you're getting into the bone, a couple millimeters. So it feels differently, so you can kind of gauge it that way.
Sure. Can you treat the posterior maxilla on the palatal side with a straight driver? Interested in molar intrusion using TADs?
I mean, I think it would be really, difficult access. I have never, that is an area that I have not done yet. But you could, feel free to get in there with, I don't see why you wouldn't be able to get decent access with that. I think you'd be fine.
Great. Have you had cases for palpable impacted cuspids, and do they present any special problems for Propel sites?
For what, palatally impacted?
Yeah, palpable impacted cuspids.
I mean, that's going to be a little bit more difficult because you're going to have more proximity to the tooth. So most of mine have not been palatal. Like they've usually been facial. But if it's palatal, I would, and obviously you want the tooth to come facially. I would, do like with Brandon, I, kind of went all over the place. I went buccal, I went lingual, I went out to, went out to the facial like a trail of breadcrumbs, and just where I wanted the tooth to go, just kind of just used it all in the whole area. So that's what I would do. It's not going to hurt.
It looks like that's all the questions we have.
Great. So thank you everyone for attending.